My great pleasure to introduce the next speaker, who I'm sure most of you, or if not all of you in this room, know well, Professor Ajith Siriwardena. He is Professor of Surgery in Manchester. He consolidated the centralised HPB Centre in Manchester. He's got an extensive research portfolio, and as you know, he's past president of EHPBA. And just to add, he is also formerly my trainer and mentor, just to add that
in. Thank you. So first of all, I'd like to start by thanking Javad. Where is he? There you are. I think you've done a brilliant job getting this together. So fabulous for doing that. Thank you, Trish, for the introduction. Javad said to me, it doesn't matter what you say, you've got to stick to time. Okay, so that's the main thing for this talk. So I'm supposed to speak about internationally validated guidelines for robotic HPB surgery. And I guess part of the privilege of my position with the HPBA was that I have been involved in a lot of the consensus meetings over the last few years. So laparoscopic liver, pancreas, laparoscopic CLAT-skin, arterial resection. And the format that those take has a lot of inbuilt bias in it. So that you get, for example, if you say the statement laparoscopic CLAT-skin or surgery for CLAT-skin should be attempted laparoscopically preferentially, the evidence for that, there isn't any. You then get it looked at by a small expert panel who say, yes, we upgrade this statement to saying, yes, it's something that we should do. So the trouble with that is that's inbuilt bias. So I'm going to take a slightly more reflective, nuanced approach. That's my disclosure slide, looking at aims of robotic surgery and methods of assessing those. Now, cancer is common, and all of us, or most of us in our lives, will have had some touch with cancer, either us or our relatives or our loved ones or parents or brothers and sisters. And if one has cancer, and this is probably such a simple thing that it's almost not worth emphasizing, if one has cancer, people out there think that if they're going to have their operation done robotically, it's going to be better. And by better, what they're expecting is better disease-free survival, better overall survival. There may be some evidence towards that, which I'll come on to later. Or, equally valid, if you can't achieve that, then you're expecting better patient-related outcomes, less sore after surgery, quicker recovery, quicker to going back to work. So, looking at the guidelines, ideally you'd have randomized trials, but randomized trials are difficult to do in surgery. That's why we have so many guidelines. What the guidelines do is they take together the stuff that's out there, put it together, interpret it, come out with something. So let's look at laparoscopic surgery, because the robotic approach is essentially laparoscopic surgery done with fixed position instruments. So this is an interesting study. I was going to be critical of this, but then I found that Brian Goh is speaking tomorrow, so I need to change my position on that one. This is the survival advantage of laparoscopic liver resection compared to open. So it's interesting. This is that very first thing I said at the start, that if you have a laparoscopic liver resection, by implication a robotic liver resection, you're going to get a better outcome, better survival. Two randomized trials, Oslo Comet, Osman Fretland's study, and the other one, and then 13 propensity matched cohort series, which showed that there was a slight reduction in the risk of death, improvement in the hazard ratio if you had a laparoscopic operation. Great. I was really fortunate to work with James Mason, who was Professor of Health Economics here. He's retired now, and he taught me, and I was really quite an ignorant surgeon, he taught me how to interpret Kaplan-Meier curves. And if you look at this one, what it shows is that for the bulk of that curve, the survival is the same. Where it separates out right at the end, the number of patients at risk is really small. So sorry, Brian, for tomorrow, but he'll show you this slide and show you how laparoscopic liver resection is advantageous. But then you will know that actually by the time he shows it's advantageous, there's only like 3 patients in it. This is the propensity match data. And when you take propensity match, you show your laparoscopic series of whatever it is, 15 or 16 patients. And from a series of 30 or 40 or several hundred open, you pick a few that match. But how you do that match makes a big difference. Do you match exactly for age? Do you match by tumors? Do you match by whether the primary is still in situ? So that introduces a lot of bias. And overall, there's a tiny little benefit. My interpretation of this for you would be that I think you can be reassured that the laparoscopic and robotic approach is non-inferior. So I think that's okay. That's important that you would want to know for saying that to your patients. Now, I've got 2 more studies to talk about. This is Orange 2, which is a great study. Some of you in the audience, I see Zahir Soonawala's here, some of you in the audience were participants in this study, which is a landmark study published in JCO. It compares laparoscopic to open hemihepatectomy. 890 patients screened, 162 lap, 160 open. Again, to interpret the study or to put a bit of nuance in the interpretation, if you do an open liver resection, you're probably home after 4 or 5 days. In Manchester, we were slow at getting people home until Declan came to us and worked as our registrar, and I still give you credit for this, that you transformed our NERAS, which is non-enhanced recovery, to something close to ERAS. So thank you for that, Declan. But so 5 days for an open liver resection, 4 for a lap, so 20% reduction. To show that, I worked out the power calculation, sad person, I realized, you need about 460 patients in each arm. To avoid it, they did a composite primary endpoint. So a composite endpoint has got a bit of clinical stuff and then a lot of functional stuff. And to these 5 things, you could add number 6, how quick you could go around Tesco's with a trolley, because that's also assessing the same thing. Or number 7, how quickly you could stay up late in the evenings to watch series 4 of Slow Horses. It's again the same thing, but each one of those individually gives you points which favor a particular endpoint. It's a reasonably well-matched series. Their primary endpoint was a mean time to functional recovery is 4.7 with lap, 5.9 with open, or 4 to 5 days. Oncologically, and that's important, that was probably, again, my important message from this talk, oncologically, we've got equivalence. So we're not really showing any harm, which is important. I realize that's not an ambitious thing to say, but it's an important thing to say. Their conclusion was that the laparoscopic approach resulted in a shorter time to functional recovery, and they said this, a shorter time to adjuvant systemic therapy, which is really misleading. In those guidelines that I was involved with, the thing that I focused on was the conclusion of the abstract. All the rest of it, I let them say what they wanted to say. The conclusion of the abstract of both EGUMILS and EGUMIPS is me, because this one I would have rewritten for them too. I'm not involved in it, so I didn't rewrite this, but a better conclusion for them. And I did check that Ronald Van Dam isn't here. Unfortunately, I presented this at a meeting and he was there. So he wasn't particularly happy with it. But so laparoscopic compared to open hemihepatectomy met the primary composite endpoint of time to functional recovery. There's no shame in saying that, with an overall 1 day earlier improvement in the lap arm. There's oncological equivalence, but there's a non-significant lower R0, higher R1, R2. And Saurabh and Thomas talked about this. And I think you can case select, so you avoid people who've got a transection very close to a liver metastasis. Laparoscopic hemihepatectomy is safe in the hands of experienced surgeons in experienced centers, otherwise undefined. And the 4th conclusion is just wrong, that time to adjuvant systemic therapy, that's irrelevant, because only 10% of patients in Orange 2 had intrahepatic cholangiocarcinoma, something where you might give adjuvant therapy. The rest of them weren't going to get it, so it's misleading. Okay, international consensus. This is the only consensus I'm going to talk about. This is Pierre-Alain Clavien's robot for HPB surgery. Used a complicated Zurich Swiss system where you get 10 panels and an independent jury. I don't think that projects particularly well. Just focusing on their recommendations. Interesting, the numbers here are different to the numbers that Adam just talked about, but it's from their paper. So 7,500 platforms and use in over 11 million procedures, lots of other systems around. 9 studies show the feasibility of robotic HPB surgery. So without doubt, moving from laparoscopic to robotic, this is feasible, practical, and safe. How do you train? What's the training and expertise in robotic HPB? So critical requirement is to have training and expertise in open HPB surgery, which this generation will have. I guess going forward, you've got to bear that in mind for the younger generation. The term expertise applies to the entire operating room team. And it's one of the things Declan pointed out to me when I went to Liverpool for a PhD, that you took your entire team with you on your training journey. So that's important. Credentialing, interesting point, and I think a fair point. The panel acknowledged the general lack of credentialing in healthcare. So robotic surgery shouldn't be held to a higher standard. There should be credentialing, probably at the center level. Training, so training programs, EHPB has LearnBot. There's a stepwise training of simulation, in-animation, video, and then surgical with mentorship. There's no justification, and I don't see that happening in the UK for self-taught surgeons. You might think, why am I saying that? But laparoscopic cholecystectomy was largely self-taught, and we should measure outcomes, collect data on disease-free survival and overall survival. So their summary recommendations were that it's feasible, emphasize the importance of expertise, and the concept of expertise was defined broadly. I couldn't find a definition in the paper. So in conclusion, taking a broader look at this, first of all, societal aspects of robotic HPB surgery, change is part of life, and surgery is a technologically driven specialty, and robotic technology is likely to continue to be developed and implemented, and that's good. The capital investment costs and the prioritization of that's a complex issue outside my scope. Vendor expectations, and I think there are vendor expectations. If you develop complex, expensive kit, then you have a moral responsibility to be involved and support training and credentialing, take care of a collection of third-party data, and for robotic liver surgery, the robotic CUSA, which is coming according to the people who make the CUSA Clarity, that's a useful addition. Patient expectations. So I think patients would be happy to have robotic surgery, but you need an honest discussion. When we started with the CMR, Sorab reconsented all the patients who'd been consented for lap chole. Said, I'm an experienced surgeon, but I'm going to be doing it a different way. So experienced surgeon, newer technique, implemented with proctorship. I think you can expect equivalent post-op and oncological outcomes with a better functional recovery. For the surgeon, it's easy to get worried about this. I would say try not to worry about the thing that everybody else is doing robotic HPB surgery except me. I said this to my colleague, so Selvin, who's here, said, I want to be there. I feel I'm missing out. I said, no, you remain focused on patient care, specifically covering my on-call today. So that was important. Follow well-described steps for training. You know, someone's got to do it. Operating room inefficiency, and I come from a hospital where this is chronic. I don't think that really matters in our NHS. But what does matter, and we'll be hearing about it later, is that I don't think we can inflict a poor learning curve on a patient population in 2025. And that's what this is about. So my last slide, I've said robotic surgery, that's the badger. So there you are. Thank you very much.
Questions for Professor Siriwardena?
My name is Zifang. I'm from Mayo Clinic, Arizona in Phoenix.
Oh, hello.
I want to ask you...
What a long way you've come.
Some of us came a long way. You brought up a good point about time to adjuvant chemotherapy. And I guess I can only speak on our experience in North America, where what dictates time to adjuvant chemotherapy is the medical oncologist secretary's ability to get the patient on their schedule. Way more than how quickly they recover from minimally invasive surgery. And I was wondering, to that point, is it similar in the UK, and whether we should just de-emphasize the focus on that measure as much as it seems like an appealing concept from a cancer perspective?
That's a really great point. It's not such a big issue across the NHS, getting chemotherapy, if it's systemic therapy, if you have a cancer without a tissue diagnosis, is a chronic problem for us. But after resection, it's not an issue. But I think we know that the SPAC data showed that you have up to 8 weeks to get to a systemic therapy after a pancreas resection. And after 8 weeks, there's a little bit of a fall off, but those patients have probably had a complication because they didn't get there. But I think your point, I think we should de-emphasize that. I think it's the functional recovery, which is better and quicker for patients. That's important.
Thank you very much, Professor.